Bismillahirrahmanirrahim. Rabbi zidni ilma. Quote of the day. A positive mindset is one of the attributes of successful people. Assalamu alaikum everyone. My name is Dr. Sadia Rafi and under the supervision of Professor Dr. Sara Alpser, today my topic of presentation is Intra-Natal Care and Essential and Comprehensive Emergency Obstetrical and Neonatal Care. Learning outlines include the introduction, objectives, antenatal care, essential and comprehensive emergency obstetric and neonatal care, recent updates, and multiple choice questions. Learning outcome includes, at the end of this presentation, my colleagues would be able to describe antenatal care and also basic and comprehensive emergency obstetrical and neonatal care. Introduction. Mother and children both are vulnerable group of community. Women in childbearing age 15 to 49 years constitute about 22% of the population of Pakistan. Children, on the other hand, constitute 40 to 45% of the population of the developing countries. This group is characterized by high morbidity and mortality rates. Maternal and child health. Healthy children needs healthy mothers. The term maternal and child health refers to the promotive, preventive, curative and rehabilitative healthcare for mothers and children. It includes the sub-areas of maternal health, child health, family planning, school health, handicapped children, adolescents, and health aspects of care of children in special settings such as daycare. The specific objectives of MCH are reduction of maternal, perinatal, infant, and childhood mortality and morbidity, promotion of reproductive health, and promotion of physical and psychological development of the child and adolescent within the family. Mother and child, one unit. During the antenatal period, the fetus is a part of the mother. The period of the development of fetus in mother is about 280 days. Child health is closely related to maternal health. Certain diseases and conditions of the mother during pregnancy, for example, syphilis, German measles, drug intake, diet intake, are likely to have their effects upon the fetus. After birth, the child is dependent upon the mother. In the care cycle of women, there are few occasions when service to the child is not simultaneously called for. For instance, postpartum care is inseparable from neonatal care and family planning advice. The mother is also the first teacher of the child. It is for these reasons the mother and child are treated as one unit. Obstetric and preventive medicine. It is that throughout pregnancy and puerperium, the mother will have good health and that every pregnancy may culminate in a healthy mother and a healthy baby. Social obstetrics. It is defined as the study of the interplay of social and environmental factors and human reproduction going back to the preconception or even premarital period. So the maternity cycle, the stages are fertilization, antenatal or prenatal period, intranatal period, postnatal period, and interconceptional period. So it is divided in, like this, same thing. Now, basically, my topic of presentation is intranatal care. Childbirth is a normal physiological process, but complications may arise. Septicemia may arise from unskilled and septic manipulations and tetanus neonatorum from the use of unsterilized instruments. The emphasis is on the cleanliness. It entails clean hands and fingernails, a clean surface for delivery, clean cutting, and care of the cord and keeping birth clean by avoiding harmful practices. So basically, this is the 5 C's: clean hands, clean surface, clean cutting, care of the cord, and clean birth. Hospitals and health centers should be equipped for delivery with midwifery kits, a regular supply of sterile gloves and drapes, towels, cleaning materials, soap, and antiseptic solutions, as well as equipments for sterilizing instruments and supplies. Aim of good intranatal care are thoracepsis, delivery with minimum injury to the infant and mother, readiness to deal with complications such as prolonged labor, antepartum hemorrhage, conversions, malpresentations, prolapse of the cord, etc. Care of the baby at delivery, resuscitation, care of the cord, and the care of the eyes, etc. Partograph. A partograph is a graphical record of the observations made of a woman in labor. For progress of labor and salient conditions of the mother and the fetus. It was developed and extensively tested by the World Health Organization. The objectives are the early detection of abnormal progress of the labor, prevention of prolonged labor, recognize pelvic disproportion long before obstructed labor. assist in early decision on transfer, augmentation, or termination of labor, increase the quality and regularity of all observations of mother and fetus, early recognition of maternal and fetal problems. Intra-natal care is of two types, domiciliary and institutional. Domiciliary. Environment must be safe and mother's health and pregnancy should be normal. Delivery is conducted at home by trained guides and health workers, female health workers, also known as domiciliary midwifery. Advantages. The mother is familiar from the surroundings, so the mother removes fear, anxiety associated with delivery in hospital. There are less chances for the cross infection, and mother can keep an eye on home affairs, children, and husband. Institutional care, about 1% of deliveries tend to be abnormal and 4% difficult, requiring the services of a doctor. Rooming in. Keeping the baby's crib by the side of the mother's bed is called rooming in. Mothers interested in breastfeeding usually find there's a better chance for success with rooming in. It also builds up her self-confidence. Maternal and child health problems, same as community, but more severe and more frequent because of the physiological state and increased demand. There's a triad of malnutrition, infections, and unregulated fertility, scarcity of health services, poor socioeconomic condition, and female illiteracy. Emergency obstetric care. Emergency obstetric care refers to the functions necessary to save lives. They are called signal functions. Signal functions are a representative short list of key interventions and activities that address major cause of morbidity or mortality and that are indicative of certain type and level of care. World Health Organization took an initiative to reduce maternal and newborn mortality by providing greater access to maternal and neonatal care through emergency obstetric and newborn care (EMON) program worldwide. This initiative is mainly focused on low and middle income countries. EMOC refers to care provided in health facilities to treat direct obstetric emergencies that cause the vast majority of maternal deaths during pregnancies, at delivery, and during the postpartum period. Basic emergency obstetric and neonatal care services include administration. Basically, these are 9 functions. 7 are included in basic and 2 are in comprehensive. In the basic, the first is administration of parental antibiotics to prevent purpura infections or treat abortion complications. Number 2 is administration of parental anticonvulsants for the treatment of eclampsia and preeclampsia. Third, administration of parental uterotonic drugs for postpartum hemorrhage. Fourth, manual removal of the placenta. Fifth, assisted vaginal delivery, vacuum extractions or forceps delivery. Sixth is removal of retained products of conception. Seventh is a neonatal resuscitation. As defined by the World Health Organization, the comprehensive emergency obstetric and neonatal care facility must be staffed by trained doctors, nurses, and midwives, and must be able to perform cesarean section, provide blood transfusion, plus all basic services. So it is in the table form. You can see the basics: parental antibiotics, oxytocin drugs, anticonvulsant, manual removal of placenta, retained products of conceptions removal, assisted vaginal delivery in the basic, plus the blood transfusion and cesarean section in comprehensive, along with the neonatal resuscitation. Again, the description of the all 9 signal functions of the emergency obstetric and neonatal care. So to avoid death and disability, we need to ensure that women have access to emergency obstetric care. The good news, not all these functions need hospitals and doctors. Well-trained nurses and midwives can perform most functions and basic emergency and obstetrical care facilities, an important point for resource-poor areas. How can we tell we are making a difference? If we know we have provided enough emergency obstetrical care, and if we know that these services are being used by women serving obstetric complications, we can be confident that we are saving women's lives. How do we know which women will experience complications? Surely we don't. But we do know that of any population of pregnant women, at least 15% will experience an obstetric complications. This is as true of pregnant women in US and Europe as of women in Africa, Asia, and Latin America. Nobody knows why this happens. It is a fact of life. Can we really tell if services are functioning and are being used? In 1991, United Nations Children Fund, UNICEF and Columbia Universities developed 6 process indicators to do just that. These were issued by UNICEF, WHO, United Nations Population Fund in 1997. These are the guidelines for monitoring availability and use of obstetric services. Process indicators. In general, process indicators show you the changes in the conditions that lead to an outcome, such as death or disability. The 6 process indicators tell us about change and assess the utilization and quality of EMOC services. Indicator 1. For every 5 lakh population, there should be at least 1 comprehensive emergency obstetrical care facility and 4 basic. It means, I have told you, in the basic, we perform 7 signal functions. And in comprehensive EMOC services, there are additional 2 more services, which are cesarean section and the blood transfusion, total of 9. Indicator 2, geographical distribution of EMOC facilities. EMOC facilities should be well distributed to serve 5 lakh people, minimum of 1 comprehensive and 4 basic facilities. Indicator 3, proportion of all births in emergency obstetrical care facilities, at least 15% of all births in the community should take place in EMOC facilities. Indicator 4, met need for EMOC services. At least 100% of women estimated to have obstetric complications should be treated in emergency obstetrical care facilities. Indicator 5, cesarean section as a percentage of all births, minimum should be 5% and maximum should be the 15%. Indicator 6, case fatality rate. Proportion of women with obstetric complications admitted to the facility who die, maximum acceptable level is 1%. This is again the summarization of all these 6 points, indicators. Calculating all 6 indicators gives you an indication of where the problem lies and where action is needed. Also, these indicators are sensitive to change. Within months, you can know if your project is making a difference. Access to emergency obstetrical care services and facilities. Problems, it does indicator 1 show you need more EMOC facilities, or does indicator 2 show you need better distribution of the facilities. So action would be most countries already have enough facility. They may just need to upgrade services to ensure 1 comprehensive and 4 basic facilities per 5 lakh population. Then the problem is, does indicator 3 show that birth in your facilities are fewer than 15% of all births in the population? And does indicator 4 show you that met need is less than 100%? That is, that not all women who experience obstetric complications are using EMOC facilities. And does indicator 5 show that less than 5% of all births in the population are by cesarean section? So for this purpose, action should be collect more information first. Do you have enough qualified staff in this case? Do you need to train staff on management of emergency obstetric complications? Does hospital management need improvement? What is the supply situation like? What is the equipment situation like? If all of the above is in place, conduct focus groups in the community to find out why women are not coming for care. And the problem, does indicator 6 show that more than 1% of the women treated for obstetric complications are dying at your facilities? Action is to get more information, find out if your emergency obstetrical care facilities are really functioning. Check staff members, skills, management capacity, supplies and equipments. Lobby your health minister for your support and get the community to lobby with you. Basically, there are 3 delay models. Number 1 is delay in seeking appropriate medical help for an obstetrical emergency for reason of cost, lack of recognition of an emergency, poor education, lack of access to information, and gender inequality. The second delay usually is delay in reaching an appropriate facility for reasons of distance, underdeveloped transportation, and medical and health infrastructure. And third delay is in receiving adequate care when a facility is reached, because there is shortage in staff, electricity and water, medical supplies are not available or are inadequate. Any country can avert maternal death and disability if it makes good emergency obstetrical care available and accessible on time. Recent updates. This was an article published by United Nations Population Fund setting standards for emergency obstetric and newborn care. It was published in 2014 and it showed all those basic and comprehensive care which was included and we have discussed already. Then there was the factors affecting utilization and outcome. These are socio-economic, cultural factors, accessibility of facilities, and quality of care. And these are also relatable to the phases of delay. First delay, which is phase and decision in seek care. Second, identifying and reaching medical facility. And third delay. And third phase is the receipt of adequate or appropriate treatment. So these are the things where the delay occur and the factors which affect the utilization and outcome. And again, according to that, the recommended the coverage for the 5 lakh people, 1 comprehensive and 4 basic EMOC services should be available. And these guidelines are available on the monitoring emergency obstetrical care. A handbook is available on it. Then the WHO recommendations, intrapartum care for a positive childbirth experience, transforming care of women and babies for improved health and well-being. In this, there is a schematic presentation of the WHO intrapartum care model, in which there is essential physical resources and competent and motivated staff is required. And in this model is like that there should be emotional support for the companion of choice, effective communication by staff, pain relief strategies, regular labor monitoring, documentation of events, audit and feedback, then oral fluids and food intake, mobility in labor and birth position of choices, pre-established referral plan, and continuity of care, respect for labor and childbirth care. Next is the signal functions for emergency obstetrical care. It was an article of intervention for reducing maternal mortality, a survey of public and private health facility in Zambia. In this, it was mentioned that maternal mortality is a global health burden and affects women of reproductive age 15 to 49 years. It is the most acute in developing countries, where complications related to pregnancy and childbirth among the leading causes of severe disability, mortality, and morbidity of women, with the report of 358,000 maternal deaths occurring in sub-Saharan Africa. Global health experts have identified signal functions for emergency obstetric and newborn care as the most effective medical intervention for managing direct maternal complications and improving maternal survival. Again, it was an article in the Journal of Pakistan Medical Association on the status of emergency obstetrical care in 4 districts of Punjab, Pakistan. In this, a cross-sectional study was conducted in Attak, Gujranwala, Rahimia Khan, and Farimganj districts of Pakistan. Total 32 healthcare facilities were surveyed, and 43.75% were with basic care and 56 were providing comprehensive obstetrical care. And in this case, there the overall fertility rate in districts was 1.75%. So the conclusion was that the continued efforts are needed to improve the availability and quality of emergency obstetric and newborn care through targeted skill-based training and provision of adequate drugs and equipments. While the federal and provisional governments want to reduce the maternal mortality ratio to 70 deaths per 100,000 live births to 2030, it currently stands at 186 deaths per 100,000 births, according to Pakistan Maternity Mortality Service. Pakistan remains one of the countries in South Asia with the highest MMR, providing skilled birth attendance and emergency obstetric and newborn care are 2 major strategies to reduce maternal and neonatal mortality and morbidity. The availability of skill provider training to deal with life-threatening obstetric complications coupled with an enabling environment consisting of essential equipment, drugs, and other supplies is crucial to the prevention of maternal and perinatal deaths. Again, it was an article, Barriers to Implementation of Emergency Obstetric and Neonatal Care in Rural Pakistan. The result in this showed the lack of teamwork, conflict management, communication, and improper power distribution are important interpersonal barriers. The significant organizational level barriers includes job insecurity, lack of organizational culture, human resource development issues, and lack of role clarity. Lack of target management, lack of resource availability, house job requirements, and dual practice issues were identified as major system level barriers. And it was the scaling up of 24/7 basic health unit strategy to provide round-the-clock maternity care in Punjab, Pakistan. In this study was done It was shown that Pakistan has persistently high level of maternal death. In government-run first level healthcare facility, the basic health units are an important place for poor and rural women to receive skilled care during delivery and birth. However, the BHU initially opened 8 to 2 times. The provisional government of Punjab has recognized all these hours of operation severely constrained access to maternity services. Therefore, the health department is implementing the 24 by 7 BHU initiative to upgrade BHUs to provide around-the-clock care. So initially 24 by 7 basic, in all BHU basic emergency obstetric and neonatal care is provided, not comprehensive. So initially 24 by 7 was started in 2010 in selected BHUs of 7 flood affected districts, which were DG Khan, Laiya, Muzaffarabad, Rajanpur, Miawali, Bhakkar and Rahimya Khan. By achieving good results of this initiative, the government of the Punjab had decided to implement it all over the Punjabs in 3 phases. 150 BHUs were upgraded in phase 1 in 16 districts in 2013-14, 550 BHUs, including 150 remaining BHU of phase 1, 1200 BHUs of phase 2, and 200 BHU of phase 3 were upgraded in 32 districts in 2014-15 as per direction of Chief Minister. All 550 BHUs have to be functioning in 2014-15. Overall, 302 rural health centers and 700 basic health units are providing maternal and neonatal child health services 24 hours and 7 days of a week in all over the Punjab. According to CDC, maternal, neonatal, and child health services during COVID-19. And in this, in step 1, pregnancy status determination. Then in step 2, the continuation of the antenatal care. The step 3 is the facility-based delivery, and 4th is the postpartum care. So it is mentioned proper checking of the pregnancy status, then the antenatal checkups, then the community refers to the basic EMOC services or comprehensive facility regardless of the COVID-19 status. Community health worker will refer the patient for the delivery, and woman delivers in a basic or comprehensive health facility with skilled healthcare personnel and COVID-19 case management if needed. Now, it's the turn for the multiple choice questions. In the reproductive age group of females, most common problem in Pakistan is malnutrition, unplanned pregnancy, unsafe abortion, pregnancy-related complications, or sexually transmitted diseases.
Unplanned pregnancy.
Yes, the correct answer is unplanned. Yes, B. Reproductive health focuses the health issues of females of 15 to 35 years, males of 15 to 35 years, females of childbearing age and their children, females of 65 years of age, male and female of all age groups.
C.
No, the correct answer is male and female of all age groups. In reproductive health focuses on all the male and females. Recently introduced component of reproductive health care is care of newborn, management of infertility, management of abortions, management of sexually transmitted diseases, prevention and control of reproductive tract infections.
D. C.
So, yes, the correct answer is C. It's the new component is the management of abortions because they lead to multiple complications and can in fact affect the future fertility of women, or even it can lead to mortality of the mother. So the management of abortions. Females of reproductive age group constitute the following part of the whole population of Pakistan: 15%, 22%, 28%, 37%, and 46%.
C. 46%.
No, to be 22%. I have told you in the start. Assessment of women's health in a community should be done by total number of deaths related to pregnancy, total maternal deaths, maternal mortality ratio, maternal mortality rate, direct and indirect obstetric morbidity. The correct answer, yes, the correct answer is C. Maternal mortality ratio is one of the indicator which is used for the women's health in the community. One of the major direct cause of maternal mortality in Pakistan is eclampsia and preeclampsia, hemorrhage, sepsis, abortion, ruptured uterus.
Hemorrhage.
Yes, the correct answer is hemorrhage. It is one of the major and leading cause of the maternal mortality in Pakistan. In Pakistan, maximum maternal mortality is associated with the following risk factors. What are those? Age of mother less than 18 years, primary gravida, grand multipara, poor previous pregnancy outcome on delayed referral.
E.
Delayed referral.
Yes, the correct answer is E. The delayed referral is one of the very prominent main cause of the maximum maternal mortalities. Mhm. During purpura, most difficult complications to manage is purpura sepsis, postpartum hemorrhage, rupture of uterus, genital fistulas, and purpura psychosis.
C.
E.
So the correct answer is D, genital fistulas. These are very severe complications and they are very difficult to deal with. So the correct answer is D. Government of Pakistan permits termination of pregnancy in case of rape, anxiety, neurosis, tuberculosis, eclampsia, and unplanned pregnancy.
Eclampsia.
Yes, the correct answer is eclampsia. It is the only known case in the government of Pakistan permits is a termination of the pregnancy because to save the life of the mother. Perinatal mortality includes all deaths of infants, neonates, early and late, only early neonates, late neonates, stillbirths, early neonates, and stillbirths.
Early neonates and stillbirths.
Yes, the correct answer is E. This is the key. And thank you so much.
Thank you very much, Dr. Sadia, as you have done post-graduation in gynecology and obstetrics. So I can see the reflection of your experience and training in gynecology and obstetrics in this presentation. It is a very good presentation, very well delivered, and a well done endeavor. The next request is please rejoin the link because the time is short and I want to have a comprehensive, concise and clear overview of all this presentation. So the time will not be sufficient for me to cover each and every point. So I would request you all to please leave this meeting and rejoin. Thank you.
Thank you.